Epilepsy is a disorder in which nerve cell activity in the brain is disturbed, causing seizures. Approximately 3 to 3.5% of Australians will be diagnosed with epilepsy at some point in their lives, and over 250,000 Australians currently live with epilepsy. If you've listened to the episode with Zoe, you would have heard her story of living with epilepsy. She is one of those Aussies. To coincide with Zoe's episode about epilepsy, I wanted to talk to an expert. I was lucky enough to find that expert in Professor Mark Cook, who specialises in epilepsy. So I know you're going to learn a lot today. Enjoy. Professor Mark Cook is with us today. He's the Chair of Medicine at St Vincent's Hospital in Melbourne and specialises in treating epilepsy. He is recognised internationally for his work, and during his time at St Vincent's, the Neurology department has grown significantly. So thank you so much for your time today. You're a very busy man.
Many thanks, Mian.
Let's talk about epilepsy just from a really sort of simple point of view. Can you tell us what exactly it is in your most layman's terms?
Sure. So epilepsy is like an electrical storm in the brain. So I guess the simplest way to think of it is that the brain's like a big circuit board, if you like, and if a part of it shorts out, that's equivalent to a seizure.
Okay.
So it's an electrical abnormality. It's produced by some error in the way the signals are transmitted, and it results in these surges of electrical activity, which constitute the seizures themselves.
And there's always got to be seizures involved for it to be diagnosed as epilepsy?
Well, yeah. You can see abnormalities on EEGs that are the same as what people have in epileptic seizures under other circumstances. But so it doesn't always mean you have a diagnosis of epilepsy if you've got the abnormality electrically. So, but that's a complicated sort of argument, and it relates to circumstances and so on. So you've got to have had a seizure at some point.
Yeah, for it to start. Yeah, to moving into that. The tests and everything involved in that.
Yeah. I guess one way of thinking about it is lots of people have abnormalities on brain scans, which don't necessarily result in any symptoms, but in other people result in seizures. So, for instance, you might have a scar or an injury of some kind on the surface of your brain from a head trauma. And because you've got that scar doesn't mean you'll necessarily have seizures, but some people with those scars do get seizures.
So they're sort of, potentially scars that have come from a traumatic incident, or sometimes they just appear?
Well, a lot of the sort of what we call, in inverted commas, scars are abnormalities of development, if you like. So as the brain's developing very early on, small accidents happen, maybe small blood vessels get blocked, or there are genetic abnormalities that cause small malformations of part of the surface of the brain.
Is that why you see epilepsy coming up so much more in children than you would developed adults?
We see a lot of epilepsy in kids. I mean, there's a peak of the diagnosis in childhood, and then there's another peak later in life. I mean, the new diagnosis of epilepsy continues throughout life, so people often think you can't get it if you're in middle age or if you're a young person, but you can. It's more common in kids to be diagnosed and in the elderly, because the elderly are often acquiring new sorts of problems on the surface of their brain, like strokes and tumours and things like this. So they've got a greater rate of the kind of abnormalities affecting the surface of their brain that might result in.
Okay, so even a mild stroke may potentially leave you with lifelong epilepsy?
Absolutely. Anything that injures the surface of the brain can potentially result in seizures.
Wow. And are there particular regions, obviously the brain is incredibly complex and there are a lot of different regions of the brain. Are there particular regions that you sort of see the worst in terms of seizures? Or is there another way in which people have the more milder symptoms to the 23 seizures a day patients?
Look, it varies enormously just from person to person. So the same region of brain with the same abnormality can produce very severe and frequent seizures in some people and very mild and infrequent ones in others. So there's an enormous amount of variation. We don't understand really what causes that level of variation. But the same abnormality on the surface of the brain or the same electrical abnormality on a recording can have quite different manifestations.
Okay. And we're talking really sort of hippocampus, amygdala sort of areas?
The temporal lobe where the hippocampus and the amygdala live is an area that seems particularly prone to be the cause of seizures, but that's in part because a lot of developmental problems seem to affect the temporal lobe, and perhaps the hippocampus is especially sensitive to injuries.
Okay.
So a lot of seizures that you see, the temporal lobe's a commonest origin of seizures, but there's, they can come from anywhere on the surface of the brain.
And correct me if I'm wrong, isn't the temporal lobe probably, I don't know how to put it, like the main area of the brain in which sort of hormone regulation is there? Isn't there sort of emotion, personality?
It's very involved with memory and emotions and things like that, and language in the case of the left temporal lobe.
Wow.
So there's a lot happening there. But the hippocampus and the amygdala are very, very old parts of the brain in a way.
Okay.
So they're very closely connected with smell and taste and memory and things like that.
Right.
Which is why seizures that originate in those areas often bring around these peculiar disturbances of memory and hallucinations of experience, like deja vu. And, everyone's familiar with auras sometimes consisting of a taste or a smell in the mouth, and that's all because this area is very involved in all of that machinery.
Wow. Because, it's really interesting to think of how it could all sort of work and be so different for everyone. Can people with epilepsy feel that seizure actually about to happen?
Yeah, so at the beginning of a seizure, as the electrical activity starts, the part of the brain that it starts in is often responsible for a particular function like memory or taste or smell or vision or movement or sensation. And if the seizure activity in that area continues for a little while, then the patient becomes aware of it. So that's how neurologists might determine where the seizures originate, by those symptoms at the start. That's what a lot of people call the aura, but it's really just the start of the seizure.
Okay.
And a lot of people's seizures don't spread any further than that. They only have that kind of warning.
Yeah.
And then if the seizure spreads a bit further to involve more brain, then typically people lose awareness to some degree.
Mm-hmm.
And in that phase is when people are seen to zone out or go blank. And during that period, with seizures that start from one part of the brain, focal seizures, sometimes people are seen to chew or swallow, do things like that. That, again, that part of the brain, the temporal lobe particularly, is involved in machinery that makes all of that happen.
Wow.
And so these episodes usually last between 30 and 120 seconds.
Okay.
And people aren't quite with it. And then it might take them a little while to recover after that. Sometimes the seizure activity spreads very dramatically, involves the whole brain, and people have what's called a tonic-clonic convulsion, where they black out, collapse and shake all over. But most adults with epilepsy aren't having them with any regularity. The sort of seizures they're having are the ones where awareness is impaired.
Okay.
So they zone out, but to people who don't know what's going on, it mightn't be apparent that something's wrong. And a lot of people are having seizures that don't get a diagnosis for a very long time because no one tweaks to the fact
So that's what's happening.
Seizure, yeah. One of the problems is when you speak to the community generally about seizures, they think you mean people are dropping and collapsing and shaking. And generally that's not the case. They're having these brief zone outs. And the start of the zone out has particular symptoms often that relate to where in the brain it's coming from.
Okay.
And so that can be very helpful to figure out where you need to look on scans and so on.
That must be so tough, though, to know that there's something happening with someone, but being able to find it, like, how does that...
Oh, well, we've made
that's a whole other world.
In that, from when I started in the area, MRIs were just coming out, but prior to that, we usually didn't find where seizures came from.
Okay.
And now we usually do find where seizures come from. Not always, because a lot of the causes are still too small and subtle, outside our resolution still. But every year there are advances in the imaging, and we were able to detect the abnormalities that's responsible in more and more people.
Even for the people that are just having that 30-second blackout. Because even 30 seconds could be quite scary.
That's exactly right. So a lot of people wonder why, if you have seizures and you just zone out for 30 to 120 seconds, why?
120 seconds is quite a long time.
It's an enormous problem, because it means it's dangerous to drive a car, and to swim, maybe to take care of little children, maybe it's difficult to work depending on what your job is. So there's all sorts of consequences of that. And of course, they're kind of unpredictable. from the perspective of the patient. In recent years, we've recognised there are patterns to them, but they're very complex patterns over often very long periods of time. And identifying these patterns, seems to be useful, but it's early days of that research, really. The point is, for most individuals, the seizures aren't predictable enough for them to be able to modify their activities to make them.
Because it's not like you see on TV shows when, they try to bring some epilepsy awareness by having a character that has epilepsy. And of course, they just use strobe lighting. Like, it's not just...
Well, strobe lighting, so when we do an EEG, an electrical recording of the brain's activity, you stick electrodes on the scalp and you do a recording of the brain's normal activity. And sometimes you see seizure activity during that. But often you might see it only when you try and provoke it. One way of provoking it is over-breathing. So in some forms of seizures, you can provoke the electrical changes with over.
Okay.
And sometimes you cause little seizures with that too, but that's especially in little kids. And the flickering lights too can, in some people who are sensitive to them, produce the electrical changes that we see. But they very rarely result in actual seizures to see. So when we're doing those flickering lights, we usually see electrical changes, but we don't usually see people have a seizure.
Just dropping straight to the floor and shaking.
The idea that people have seizures when they get strobe lighting, and then in theory it's possible, but in the real world it's pretty rare.
Not so much. I guess TV is a visual medium. They have to have something obvious. But
it's a funny thing, people know almost nothing about epilepsy. What they do know is they know major convulsions. They know that you swallow your tongue, which you don't.
Yeah.
And they know that flickering lights bring them on. Everyone knows that. I don't know where they learn it.
TV.
Yeah, it's ridiculous, And the swallowing your tongue thing often leads to injury for people because well-meaning bystanders often try and put things in people's mouth when they're having a seizure.
And they would shatter their teeth, wouldn't they?
People often bite their tongue during a seizure, but you don't swallow it.
No, it's pretty difficult to swallow a tongue. Like, it's sort of designed for a reason. Well, let's go sort of back to the beginning. I got a little bit too excited speaking about the brain, and we haven't really chatted about you as such. What brought you into this world? Why neurology? Why epilepsy?
Well, I was always really interested in neurology. Everyone's interested in neurology, right?
Yeah.
And there are popular books about neurology that people are interested in because the brain and the mind is something which interests just about everyone. Everyone alive is interested in how it works and understanding it. So everyone likes neurology, and all medical students like neurology. Conditions are so interesting, and the manifestations are so complex, and so everyone likes it. Of course, it's very different reading about it than actually practicing it, because few people are research neuroscientists just sitting around analysing all the complexities of mind and consciousness and so on. So in practice, it's a bit different than it might appear reading Oliver Sacks books, for instance.
Okay.
So, but nevertheless, it's great and fascinating work. And there have been so many advances, over the past few decades in neurology. So those are really good things. So it was always of interest. I became interested in epilepsy because my dad developed seizures, and his seizures were very difficult to control, and so that got me interested in epilepsy particularly. And then by chance, I was offered a job doing neurology as long as I was doing epilepsy as the main focus. So it was meant to be.
Been to you the best advances that you've seen over the last 10, 20 years?
Oh, well, MRI imaging's been, just such a spectacular advance. And, the changes that brought about in, increasing opportunities for it to understand how the brain works and what the causes of seizures are, and, whether they might be, suitable for surgical treatment and so on. All these findings have been, really important and dramatic. And the other's just been the improvement in the number of medications available, because, when I started, there were really only 3 major anticonvulsants that were in routine use, and now, there's over 20. And unfortunately, the number of people who aren't controlled adequately by the medications is still about the same. So about 30 or 40% of people still aren't adequately controlled despite all these new medications.
Okay.
So why is it good to have all these new medications? Well, because the side effects of a lot of these medications are dreadful.
Oh.
And they're, again, highly variable between individuals. And having as wide a range of medications as you can possibly find to be able to offer people all sorts of alternative treatments is terrific. I mean, 30 years ago, I had patients who took medications for dreadful side effects, and it was the only thing that worked for them. They had to take it. They were stuck. And often, and still people say this to me sometimes, the diagnosis was bad, but the worst thing was the treatment. So they're getting stuck. They're obliged to take the treatment because, they need to drive and work and so on, and yet the treatments can have bad side effects for them. Because, of course, the drugs work on your brain and they affect in some way the electrical activity of the brain, and they're meant to stop, abnormal electrical activity. But there's sometimes not a sharp distinction in terms of how the drugs work, and so they might dampen the normal brain activity to some extent as well.
Right.
Now, most people will take their medications without any trouble, but some people have awful side effects, and it can be a really long job finding the one that suits them best. And even the one that suits them best might not be perfect. So I'd say the drug advances have been pretty significant, and so I'd put them down as the big ones. But I mean, a lot of things have happened around the edges. Important things like our ability to collect and analyse the EEG signals and to understand them better, and to recognise these patterns of seizure activity, which have been very important to me. And, personally, the biggest development has been the recognition that there are these deep cycles to seizure activity, which can let us forecast seizure activity if you've collected enough information. And I guess one of the tasks we're about at the moment is figuring out how to collect enough information.
I was about to say, how do you even collect enough information? How long does that even take?
That's right. So EEGs collect the brain's electrical activity, but only over snapshots, so 30 minutes, sometimes in hospital for up to a week. And we did a study over 10 years ago now where we put electrodes in the brain of people for up to 3 years and recorded it very accurately, and were able to show that it was possible to predict seizures. And since then, we've been working on a less invasive way of collecting that information. And so we've developed a device that goes underneath the scalp with electrodes, not inside the skull, but outside the skull, just underneath the skin of the scalp. Could have put there, that could potentially stay there for, many years, perhaps lifelong, to record the EEG continuously. And then we can analyse that seizure activity and use it to predict seizures.
But it still takes, quite a few years on one particular individual. So
it depends how many seizures they're having, or how many electrical events they're having that we can use. And so it takes many months or many seizures before you can start to see these patterns.
Right. Okay.
So yes, it needs to be over a long time, but we have developed a system that does that.
Amazing. But it's the same as really everything. It's like practice. You have to see a few times before you're aware of what's going on.
That's right.
It is going to take time.
And again, with these patterns, there's enormous individual variation. So there's some fairly common patterns. So a lot of people have a pattern around about 24 hours, and a lot of people have one around about a week. A lot of people have one around about a month.
Okay.
There are many, many other patterns, and finding them for an individual and finding which are the important ones for them takes you a little bit of time.
That's incredible.
But once it's done, we're expecting that we'll be able to give people useful forecasts of when their seizures are likely to occur. And I'm hoping that will give them a great degree of freedom, because, of course, a lot of the restrictions now, because of the uncertainty of the events and the unpredictability of when they might happen.
Well, there's a lack of independence for them in terms of not being able to drive, in terms of, not being really allowed any heavy vehicles. And as you said before, that limits the work as well. So this way you've got, I guess, proof for them that the medication is working and that they're moving on with their life.
Well, that's exactly right. If you've got devices in like this, you can actually see the effects of treatment and whether people are perhaps having more seizures than they're aware. Because a complex thing about seizures is that because many of them start in areas of the brain which are concerned with memory, they disrupt that memory. And so People can be having quite a lot of seizures and not be aware of
Not
it.
know.
So another big challenge, managing epilepsy.
Okay, so it takes either way, it's going to take a long time to that diagnosis and to finding what's going to be the right pattern, right medication, right
And then
process.
figuring out what's actually happening
Yeah.
is a problem, because one of the reasons that epilepsy has been difficult to manage is because we don't really have a good way of measuring what's happening to the seizures.
Okay.
I mean, if people are having major seizures, well, generally you can identify them. The little ones where people zone out briefly, well, they're not easy to count, because people might not always know when they're happening. If there's no one with them when they happen, then there might be no record of them. Sometimes even when they're with people, they don't recognise that an event's occurred.
Yeah.
So trying to fix that is hard if you don't know what it is you're fixing.
What it is you're looking for. You could just zone out because you're a little bit tired that day and not interested in what's going on.
Yeah. So, we've been very interested in ambulatory monitoring, where we put an EEG on and send people home with a video for a week or so. And we record them. And what we find is that a lot of people are thinking they're having seizures when they're not.
Okay.
A lot of people are thinking they're not having seizures when they are.
Right.
And it's been really eye-opening. So that's, the ability to do that is another big advance. It's not a scientific advance in a sense, but it's a practical advance that you can put the technology out there now to people's houses and see really what's going on in the real world.
Which makes it so much easier because it's their natural environment as well. Do you find that makes a huge difference in being able to know when they're having seizures or see the seizures to, say, clinical? Like if you put them in a hospital for a week, is that different? Would they have less seizures naturally?
Well, often what we do in hospital is when we deliberately try to record seizures, we stop people from sleeping and we withdraw their medication or reduce their medications to provoke them. That might produce seizures which aren't their normal ones.
Yeah, because they're not on the medications that they'd normally be on.
That's right.
And normally not being kept awake unless they're doing some horrible army camp.
That's exactly right. Okay. So catching them as a natural setting as you can. So catch them in a natural setting, but also catching them if you can over very, very, very long periods of time, months and years, I think is going to be really important.
Okay.
Because a big problem with epilepsy and our understanding of it is it comes through these, like looking through a keyhole. And the hospital admissions with an EEG, we're seeing a tiny fragment of how it behaves over someone's lifetime. And the ability to capture the information over very long periods resulted in a very different understanding of what's actually going on.
So fascinating to see the differences that can be made with something as simple as, video. Obviously, being able to have electrical impulses going to the brain is very different to just having a video as such, but being able to do that in such a non-surgical way that it's, it's not touching their brain, it's not affecting them as badly. Was that quite an exciting advance? Because obviously opening up someone's brain to add the pulses to them is very, very different. Attaching anything to the brain is really quite dangerous. It's quite a tender organ.
Yep. Always involves some risk.
It always involves risk. So being able to do that, does that mean more patients can be opened up to doing this practice and the research and following and seeing what their seizures are like?
Well, that's the hope. So this is work that's in trial at the moment, and where we've been for the last few years putting these devices under people's scalp and recording them. Now we've got recordings out to about 4 years.
Amazing.
So, you can do it.
Yeah.
And this will change things ultimately, how we manage epilepsy. And it's like the heart. So, there are implantable devices now to monitor your heart and its regularity and whether there's something wrong with how your heart rhythm is going. And these have been very important in cardiac management, and they will be in epilepsy as well. But it's early days, and so trying to understand what it is we're collecting and how long we need to collect it for are all things that we're doing right.
Amazing. So it is sort of really finding that finer detail, and hopefully, in your lifetime, you'll be able to go, cool, for 5 years, you have this monitor attached to you and this is what we find, and we know what the medications are going to be at the end.
Yep.
Do you ever think there's going to be a cure of something like epilepsy?
Look, maybe for some kinds of epilepsy, it's hard to fix epilepsies that are a result of very extensive direct damage to the surface of the brain. I mean, if it's a small enough area, we can remove it surgically.
Okay.
That can cure it. I suspect, some of the genetic cause of epilepsy, I mean, in theory, if it's something that can be identified accurately, and it might be then something that can be in the future fixed, like some other genetic diseases can be through engineering. But I think that's a way off yet.
Now, many years ago, we actually did a video. I did a video with you and one of your patients, Natalie, going through a trial in which you actually inserted, I think, was it from her stomach? And it actually took the medications directly to the spot in her brain where the seizures were coming from. She was having 23 to 30 seizures a day and quite...
Oh, she was terribly...
terribly.
So she was the first patient to get one of these pumps put in. So it's a pump under the skin of the belly. And these pumps are used normally to deliver drugs to spine and places like that for pain and spasticity. But we placed it so that the pump could deliver drug directly to brain. And so we had to drill a small hole in the skull, and a fine tube is passed through into the fluid-filled areas deep inside the brain so the drug can get there instantly and directly. And that's been very dramatic. Again, it's still early days, and it hasn't worked for everyone, but for a lot of patients it's worked extremely well. And for some it's just been spectacular.
Absolutely brilliant, because I remember, I think she hadn't had it in for a very long time when we did that video in 2016. And she was already she was done. She wasn't having any seizures. She hadn't had any while she was post-procedure. And she was able to sort of live her life with her daughter and her family. It was just incredible. And it's so exciting to know that she's still doing so well.
Yeah, that's right. So she'll be in the 8th year of this now and still had a benefit. So it's been terrific.
So do you think something along, a procedure like that, is that going to be something that can be regularly used once it's sort of done the research base?
I hope so. I mean, we've had a trial going for a while, and then we had a second trial that followed on from that involved many centres around Australia, and then it expanded so that there were centres in Israel recruiting for the trial, and I understand it will be moving to other countries in the not-too-distant future. But it's such a slow process developing a new kind of treatment, and obviously this involves surgery, and it's new, and there's still uncertainties around how well it might work and for who over what sort of period of time. So it takes a long time to work.
Because it's not a day procedure still. It's still quite an invasive surgery.
To put it in, absolutely, yeah. So you've got to pass that fine tube through the brain, and the tubing's got to be tunneled down under the skin of the chest, and the pump put in the belly. So there's a bit to do. And
yeah, it's big.
Yeah.
How do you feel? Obviously, there are reasons that things are quite slow in terms of medical breakthroughs, for want of a better term. How do you feel about how long sometimes these things take?
I used to not understand it at all, but, because I've been involved in developments like that and these other things with the implant, you see that the processes around them, it's just very hard to make them move quickly because a lot of experimental work needs to be done, and then there's a lot of regulatory issues to deal with, and unfortunately, the reality is that you need to find some way to pay for it. So you need investors of some sort, whether that's government bodies like the National Health and Medical Research Council, or whether it's a company that's investing in developing them. There's all sorts of possibilities, but whatever the possibility is, it's hard and involves keeping people involved over very long periods of time often. And so I guess, 20 years ago I wouldn't have had much understanding around just how complicated all that part of it is.
Okay.
But now I know.
Now you know, and it makes sense.
Yeah, well, a lot of these processes are put in place to protect people, obviously, to make sure things are as safe as you can get them. There's always some risk involved in doing new things, and people have got to do that, otherwise we will never get anything new. But there's a lot behind it all.
Okay.
And to get through the regulatory authorities and show them that it's safe and effective and so on, they're
and I think Australia's probably got one of the I guess tightest pharmaceutical and medical rulings as such as well?
They're reasonably strict, and so
Yeah.
you need to show them the goods. The same with the
There needs to be proof that,
American authorities and so on. But all of these aspects of developing new treatments and technology are something which the ordinary person has no insight into. They just wonder, why new drugs just aren't made available all the time if people are inventing them. But it's not that straightforward.
It's not, is it? And then, of course, as you said, it's had to go to Israel. It's going into the US. It has to be a worldwide approval process.
Well, they're not necessarily for approval, but you need to get enough people involved, and you need to design a trial that's perhaps looking at a particular type of epilepsy and focus very much on showing that in a specific group that it's effective.
Okay.
Then move out from there. So, yeah, it's slow.
It's slow, but it'll be worth it in the end.
I'm hoping so.
I was assuming the MRI took a long time as well.
Yeah, well, that's right. So, getting MRI imaging out, the MR technology was around a long time before it was available clinically.
So is there, for any of our listeners that do have epilepsy, they're working their way through it, whether they are like Zoe, their medication's working, they haven't had a seizure in 3 years, or they're just starting their process, is there any advice that you like to give your patients around how to live with this disease?
I think probably the most important thing is to learn as much about it as you can and have as good an understanding as you can, because it's the uncertainty often which, makes people's life hard, and not appreciating how important lifestyle measures are. So especially with regard to sleep, so keeping regular sleeping patterns is most important, because not getting adequate sleep is a good way of stirring up seizures. So that and just making sure that you stick to your medications regularly and you've got a good routine about all of that. These are really important things from a day-to-day management point of view. I guess the most important thing for people to know is that they'll still get on and live their lives as normal, and it's a problem which for some people will be a very hard problem to manage, but for most it'll be manageable, and it'll be something that they'll work around.
Okay.
And when I see people with a new diagnosis, they're often quite despondent, as you'd expect, and very angry often about the restrictions which are imposed on them. But it will work out well for just about everyone. For some people it'll be tough, and for some people we won't find a treatment that works well enough for them. But most people will do fine. And understanding it as well as you can, I think, takes a lot of the mystery out of it, and the disturbing elements are often just because people don't appreciate, what it is they're experiencing, and making sense of all that, and having a basic knowledge of what seizures are, I think is really helpful.
Incredible.
I think there's a lot happening in epilepsy and, worldwide, but, in Melbourne we're lucky because there are so many centres that are involved in the management of epilepsy in Melbourne, so it is a bit of a global centre in a way. There's probably more research comes out proportionally out of Melbourne than anywhere else.
Wow.
So it's just one of those accidents of history that it's happened like that. But there's an enormous amount of research going on. There's all sorts of new therapies being developed. So I think it's a really exciting time and will continue to be so. So I guess the message for people out there is don't give up. Even if you're one of those people who haven't been able to find something that works properly for you, there are new things happening.
And there's people around to support you.
There's people around to support, and the support groups such as the Epilepsy Foundation, of course, have just been so important in making all of that happen for people, getting them to the right help when they need it.
Amazing.
I don't think we can possibly underestimate their value, because a lot of the consequences aren't things that the medical staff can deal with. It's the social and employment and all these sorts of aspects, and that the foundation is just so good at pointing people in the right direction and providing the support that's necessary for that.
Yeah, that's fantastic, because you really can, medical do have to stay medical. They can't help with the lifestyle. They're not support workers. They're not psychologists.
Or I should say, they only have a certain range of skills. And, people often need skills like from social workers or psychologists or others who are able to give them the support that they need. So accessing them is a tricky bit for them. The foundation's great, though, making all of that happen.
That's brilliant. Tell me about new developments that are happening at St Vincent's Hospital. What's next for St Vincent's in Melbourne?
I guess, I've been very interested in the engineering aspects of therapies, whether we can design new technologies that will allow us to better manage seizures and other conditions. And I guess the implant that we can put in that records the EEG continuously is an example of that. And so at St Vincent's, we've developed this new centre, the Aikenhead Centre for Medical Discovery, which is meant to bring together engineers and clinicians to accelerate the development of new ways of fixing conditions, not just in neurology, but across the board. Because I think whilst there are lots of research facilities around that are about looking at cell biology and all sorts of basic science approaches to how we understand and treat disease, which are really important. But an aspect which we haven't really done so well is see how we can bring in new technologies which are developed by engineers and material scientists and others who we don't generally deal with a lot directly as doctors, and getting them into an environment where they can understand the problems that we're dealing with and bring new solutions, I think is really important. And I'd say, the work that I've been involved in over the last 20 years with all of the understanding of seizures and the implants and so on has depended on having engineers and mathematicians, people who can look at all of this data in a very different way. And that's what has let us understand these patterns and rhythms which underlie cycles of seizures. So it's a really novel development at St Vincent. So it's being built as we speak. So the building's rising up out of the ground on the corner there at the edge of the hospital in the city. And, that will bring together these people from all different fields and as well bring into that the medical education process along with the education of engineers so that we understand these conditions from different perspectives.
Wow.
Because I think, we in medicine, we do get a little bit blinkered. I think, to bring people in who look at things, have different methods, who have different approaches to problems is really, really vital. That's what we're doing at the moment. But the Aikenhead Centre is a really big project, and a lot of it relates to these engineering solutions to epilepsy, such as the pump, such as the chronic monitoring. But there'll be, most areas of medicine will have opportunities here.
That's incredible. So it's really bridging that gap of all of the people and all of the knowledge all in the one space.
Exactly.
So while you're working on the medicines for the pump, that could be faster. Someone's actually potentially making a smaller pump that's more efficient all at the same time.
Pumps and for someone to have thought of this solution, that takes someone often from outside the usual field.
Still quite a creative engineering mind. That's really interesting. And that's all happening in Melbourne. Does that mean that Australia is going to have some of the best medicines and procedures in the world?
So it'll be a unique facility. I mean, there are other bioengineering centres in other places, but nothing quite like this where it's built directly into a clinical environment. And it has the educational components built into it as well. So it'll be really novel.
That's fantastic. And I guess the educational components will mean it continue on as well and bring people through.
The big problem getting all of these things to happen and working with all these different fields is because, you go to university and you get taught a different language and you really can never communicate with all those people again. And they don't understand what it is you're trying to solve and why you're trying to solve it. And we don't understand what technical abilities they have and what they can be applied to. And so they need to be brought together.
That's brilliant. When's this all happening? When's this finished?
Right now. Should be finished the end of the year.
Congratulations. That's going to be a really exciting time.
So it'll be a huge boost for the hospital and for Melbourne and of course, nationally.
Amazing. And there's so many things happening within St Vincent's, within the medical that, as you said earlier, no one really knows about.
That's right.
There's so much still happening. Brilliant. See, I was here nervous that everyone was leaving Australia to be able to to create these new developments?
I think we have great opportunities in Australia. And, a lot of it comes down to getting funding. But, if you're producing new things, new ideas, new materials, technologies, solutions, then people will come to it.
Amazing. Thank you so much.
Pleasure.
If you like us, please follow us on Spotify or Apple Podcasts, and of course across your social media on Instagram at Chronic Convos Podcast and TikTok chronic.convos. This podcast was recorded on Wadawurrung land.